Hello and welcome to another episode of MRCP Teaching by Dr. Raza. Today we'll be talking about coagulation disorders. Before diving into the disorder, I would like to touch upon the prothrombin time and activated partial thromboplastin time. Prothrombin time or PT measures the extrinsic pathway that is responsible for the fibrin clot. Factors 1, 2, 5, 7 and 10 are involved in extrinsic pathway, and if there is any defect, it leads to increased prothrombin time. Vitamin K deficiency also leads to increased prothrombin time. It is the best test to monitor warfarin therapy. So if the patient is on warfarin, the best test to monitor is prothrombin time. It also determines the hepatic function because the factors are synthesized in the liver. What happens in extrinsic pathway is that there is a damaged endothelium that leads to the release of tissue factor, leading to factor 7 activation and common pathway activation. Vitamin K deficiency leads to increased prothrombin time, whereas APTT or partial thromboplastin time is usually normal in vitamin K deficiency. A common scenario comes that if a patient is on long-term antibiotics like cephalosporins, cefepime, so it changes gut flora that leads to vitamin K deficiency. It impairs gamma carboxylation of factors 2, 7, 9, protein C and S that leads to increased prothrombin time. So these antibiotics, they primarily mimic the action of warfarin or prothrombin time. Another common concept is of activated partial thromboplastin time. So it is responsible for all the factors excluding factor 7 and 13. So if there is any defect in any of the factors excluding factor 7 and 13, so APTT would be increased. It is also increased in hemophilia or sometimes in von Willebrand's disease. It is the best test to monitor heparin therapy. However, heparin also increases the prothrombin time. It monitors intrinsic pathway. So the common factors in intrinsic pathway are 12, 11, 9 and 8. So APTT is elevated during heparin therapy, hemophilia, von Willebrand's disease, and APLA. So the commonest cause of reduced or decreased APTT could be in vitro clotting cascade activation. So the tests are usually repeated to exclude pathological causes of hypercoagulability. It is important to differentiate between disseminated intravascular coagulation and thrombotic thrombocytopenic purpura with the help of coagulation studies. So TTP and HUS are the microangiopathic hemolytic anemias in which PT, APTT are normal, whereas platelets are decreased. In DIC, there is increased prothrombin time and activated partial thromboplastin time with decreased platelets. There are certain isolated factor deficiencies that lead to increased PTT, normal PT, and platelets. Hemophilia A, that is factor 8 deficiency, hemophilia B, factor 9 deficiency, and von Willebrand disease can lead to increased activated partial thromboplastin time. Giant platelet or Burnett-Sollier syndrome is another commonly asked question in the MRCP exam. So it is a genetic defect in glycoprotein 1b that causes problem in platelet addition. There are increased megakaryocytes and abnormally large platelets in the peripheral smear. It is characterized by thrombocytopenia with elevated bleeding time and normal PT and partial thromboplastin time. It has to be remembered that ristocetin test is used to differentiate Burnett-Sollier syndrome from von Willebrand disease. So ristocetin is an antibiotic that binds von Willebrand factor to glycoprotein 1b and leads to agglutination in the normal blood. Either defective von Willebrand factor or glycoprotein 1b, so the platelets will not aggregate in the presence of ristocetin. If the normal plasma is introduced in the same blood, so it will correct the defect in von Willebrand's disease. However, it will not correct the defect in Bernard-Sollier syndrome, that is the platelet receptor defect.